Hello everyone. Let's have a quick revision on the anatomical and the physiological changes of airway in an obese patient. So first is they have an increased amount of submucosal tissue in the oral cavity, pharynx. They have a larger tongue and they have increased size of the tonsillar pillars, and they have encroachment of the posterior pharyngeal wall into the pharynx, which leads to the increase in the Balampetti class and CL grade view, which makes lesser space during laryngoscopy. Next is that they have increased amount of subcutaneous adipose tissue in the anterior and the posterior neck, which leads to the decreased anterior mobility of the pharyngeal structures and decreased neck extension during laryngoscopy. So next is that they have the abdominal fat lead to decrease in the lung compliance, that is secondary to the pressure over the diaphragm during inspiration in a supine position. This leads to less effective pre-oxygenation and increase in the airway pressures. Next is they have a decreased expiratory reserve volume from the collapse of the smaller airways, resulting in the ventilation perfusion mismatch, which is exacerbated in a supine position. They have a decreased functional residual capacity, smaller oxygen reserve, and a rapid oxygen desaturation during periods of apnea. Last is they also have obesity, have an increased risk of aspiration, that is due to increase in the intra-abdominal pressure and a larger gastric volume. So these are the changes. Hopefully this will be useful. Thank you.